for disease-specific care, as well as TJC, which stands for the Joint Commission. As the speaker announced, I am from CMC, Department of Neurology, or Carolinas Neuromuscular ALS MDA Center. To give a little bit of background information on our center, it was established in 1998. It's comprised of 12 different disciplines that are all dedicated to clinical care and research for ALS patients, and we currently have approximately 200 patients that we are serving with ALS. We are part of Carolinas healthcare system, which is the third largest healthcare system in the Southeast. We have facilities in both North and South Carolina, and pertinent to this discussion, in our system, we currently have 43 programs that have various disease-specific certifications. And this map, I know, is a little busy. This is a Dr. Brooks favorite. But what we're trying to show with this slide is basically, it's a map of North and South Carolina. The general population is right around 14 million. The prevalence of ALS in North and South Carolina is right around 600, with 170 new cases per year. The blue dots on the map represent the different ALS treatment facilities across both North and South Carolina. Our center is circled kind of in the center of the map, and we're situated near the border of South Carolina, which we draw most of our patients from North and South Carolina. So what is the Joint Commission exactly? If you live in the United States and you work for a big healthcare organization, when you hear the term the Joint Commission, there's a certain level of anxiety that's associated with that. They are our nation's oldest and largest standard-setting and accredited body in healthcare. And it's a non-profit organization. It's independent. It currently evaluates and accredits more than 19,000 healthcare organizations and programs in the U.S. And it's designed to improve safety and quality of care. They're big on supporting performance improvement in organizations to provide them with accreditation. And the DSC program is a branch of the Joint Commission that provides certifications to more than 1,000 different disease-specific care programs. And it should be noted that there is an international branch of the Joint Commission. So what exactly is DSC certification? The DSC certification program was launched by the Joint Commission in 2002. It's designed to evaluate clinical programs that are delivering care to a defined patient population, and organizations can seek this certification for virtually any chronic disease or condition. So the process for DSC certification is very involved, and more involved than 15 minutes will allow me to go into. So we're going to focus mostly on performance measurements, which is a component of the DSC certification, but you start by submitting your application to the Joint Commission, which includes your chosen performance measures. They will eventually schedule a site visit where one of the reviewers will come and review your program. During your review, you have to have at least 4 months of data on your measures, and what they're looking for is to see that your center and your program is compliant with national standards, and also that you're following your clinical practice guidelines to optimize and manage patient care. They also want to make sure you have an organized approach to performance measurement and performance improvement, which is very, very important with this process. Programs that are successful in demonstrating compliance are given a certification for a 2-year time period. During that 2-year time period, you are required to regularly submit data to the Joint Commission showing that you are continuing that performance improvement process. And then the cycle repeats itself every 2 years. They come and do a recertification visit for you to maintain your certification. So, choosing your performance measures. You have to have at least 4 performance measures. At least 2 of those 4 measures have to be related to clinical processes or outcomes and must be based on your current clinical practice guidelines. The other 2 can also be clinical, or they can be related to another program activity like an administrative task or patient satisfaction. They need to be based on logical data collection calculations, and this is set by the Joint Commission sampling protocols. They tell you how many charts you have to audit and the process for validating that information. They need to be useful to your individual program and organization. They have to serve a purpose, and they need to be within the provider's control. You have to be able to influence a change in those measures. So because they're big on performance improvement, we follow the PDSA model for performance improvement. Stands for Plan, Do, Study, Act. The plan is the goal that you're setting. The do are the things that you're going to put into place to try to be successful and attain your goal. The study is doing those chart audits and validations and looking at your data, seeing where you are with your measure. And the act is the next steps that you're going to take. And the cycle just continually repeats itself. So getting into our specific measures that we've been looking at Carolinas ALS Center, our first measure is respiratory management. Our goal or plan was that 100% of patients with ALS would have a forced vital capacity or FVC screening at every visit. This does not include patients on permanent trach and ventilator, they were excluded. And also that a respiratory plan of care would be followed, and that's to make sure that appropriate interventions are being done based on the FVC score. Currently, as of third quarter 2012, we have maintained 100% compliance with this measure. So we plan on asking to retire it and replace it with a new one. So when you ask to retire a measure, you're showing that you've met your goal. It's ingrained into your program. It doesn't mean that you stop doing it. It just means you stop reporting on it and you move on to something else. Our second measure was on depression assessment or screening. The tools that we used were the Patient Healthcare Questionnaire 2 and 9, or the PHQ 2 and 9. We administer the PHQ-2 to every patient at every visit. It's a simple 2-question, yes or no answer. If they answer yes to one or both of those questions, they're screened with the PHQ-9, which is a more detailed depression screening. So our plan with this measure was that 100% of patients that had a positive PHQ-2 would also have that PHQ-9 screening, and also that we would follow a depression plan of care to make sure we were appropriately treating depression and addressing it. As of third quarter 2012, we're at 93% compliance with this measure. And even though we haven't met 100%, we've consistently been at 90% or greater. We kind of feel we've hit our ceiling with this one. And we are also going to ask to retire this and replace it with a new measure. Our third measure is cognitive assessment. For this measure, we use the Mini Mental Status Exam, or MMSE. Our goal with this was that 100% of new ALS evaluations would be screened with the MMSE, and that a cognitive plan of care would be followed. As of third quarter 2012, we're at 100% compliance with this one, so we're also going to ask to retire it. Our fourth and final measure is communication with primary care physician, or PCP. Our plan was that the PCP would be documented at every visit and copied on the dictation 100% of the time to make sure that there was that continuity of care among the specialist and the primary care physician. As of third quarter 2012, we're at 97% compliance with the documentation piece, but only at 68% compliance with the PCP actually being copied and forwarded those dictations. So we want to continue to look at that compliance piece with copying the PCP on the dictation, because we still have some room to grow with that measure. You've probably picked up on the fact that 3 of our 4 performance measures we are going to be asking to retire and replace. So we've identified a couple potential replacement measures. One of them has to do with riluzole monitoring. We know that patients that are on riluzole have to have liver function testing periodically. So we did a 3-month chart review to see how compliant we were with doing these liver function tests per the protocol. And we were only at about 60% compliance for that. We also looked at pneumonia vaccination status. We did the 3-month chart review to see how often we were documenting the status, and that was if the pneumonia vaccine was given during that visit, if they had one in the past 5 years, or if the patient refused, and we were only at 28% compliance with that one. And the third measure we're looking at is PEG education and intervention. We know that per our guidelines, when the FVC starts to drop below 50%, you're at increased risk for complications during PEG placement. So we want to make sure that there's documented education when it starts to drop below 60%, so that we're giving them that education early, and hopefully they'll be more accepting of it at a good time. We were only at about 73% compliance with this measure, which is pretty good, but we want to get it up to 100. So, why should programs consider or look at DSC certification? I think that all of us in this room strive to provide the best patient care possible. We're here because we care about this disease in our patients. But the process of disease-specific certification through the Joint Commission really puts a microscope on your program, really makes you take a step back and consider the things that you could stand to improve on, and it gives you a framework for structure and management of how to implement that. And by having that structure, you kind of streamline your process, so you reduce variation in how you're treating one patient from the next. Receiving the certification promotes a culture of excellence in your organization. It's well recognized. Patients want to come to a center that's certified, they believe in you. And also, this could become increasingly more important with healthcare reform, but it is currently recognized by selected insurers and other third parties, so who knows what role that will play. The references are the Joint Commission website in both national in the States and international, and I would encourage you to look at those websites if you're interested. Hopefully you all were able to see some of our other posters yesterday and this morning that kind of relate to other aspects of our clinical care. And this is a picture of my fantastic team. This is definitely not a one-man show, it's a joint effort. It takes a team to make this work, and I'm grateful to work with such wonderful people. And I welcome any questions. Thank you.
Thank you. Thank you. That clearly represents a great deal of work, but I think we have time for questions. Laura Clausen.
Hi, great presentation. I'm just curious though, was there a cost incurred for this Joint Commission evaluation?
There is, and I don't actually know the specific cost. Our healthcare system bundled multiple programs on the same application. I think we have like 16 or 17 programs that were put on the same application. So I'm not sure what it is for specifics. It's probably on the website though, a specific, program.
Great. And then my second question had to do with what did you use for standards of care in developing your respiratory care management program? Was that the practice parameters?
We use the practice, the AAN guidelines were obviously our framework and our clinical practice guidelines. And our respiratory clinic here is a tool that we created. The top part of the tool had the screenings, the FVC, the NIF, the peak cough load, just some of the measures that we routinely do. And then the bottom portion served as an order sheet, so the physician could kind of see what the respiratory status was and then order interventions like 5-pack, cough assist, suction. So we were making sure that that was being filled out.
I'm sure you share that with somebody.
Absolutely.
Are you being reimbursed at any higher level than any other clinics as a basis of this joint accreditation?
No, and we actually haven't received this accreditation. We're due for our site visit next week. So, but I don't think that it affects any level of reimbursement.
Thank you for your information. In the Joint Commission style, are there surprise drop-in visits at disease-specific?
So for your initial certification, you're supposed to be given a 30-day kind of heads up. So they give you a 90-day window, so you kind of have a time frame of when they might come, and then they have to give you a 30-day